Thank you, sir. I don't think intermittent exotropia is that complicated, but then this is a child presenting to you, a 3-year-old child presenting to you with parents complaining of intermittent squinting. You can see well here, she is orthophoric, but then when you do the cover test, and then when you take the cover, try to break the fusion, there is exotropia. This is a classical case of intermittent exotropia. So intermittent exotropia is one of the most common forms of strabismus, and there is an incidence in the rise in Asia, and we have seen that it's almost 20 times higher than in esotropia, and almost more than 70% of all exotropia is intermittent exotropia. And Jenkins has also shown that regions near the equator, there is a lot of prevalence of exotropia in that in that area. So this is again another child. As we can see here, it is an exodeviation which is intermittent, which is controlled by the fusion mechanism. So unlike pure phorias, intermittent exotropia spontaneously breaks down into manifest exotropia. So if you look at the etiology, there are a lot of theories have been proposed. Duan proposed the innovational theory where there is a imbalance between the accommodation and the divergence, and then the Balchovsky's mechanical factors, which says about the size and the shape of the orbit, and also the defective fusion has a role in inducing intermittent exodeviation, role of accommodative convergence to accommodation ratio, and then theory of hemiretinal suppression, and then role of refractive errors. Again, the accommodative convergence comes into role here, and sensory adaptations have a role in etiology. The classification is very important because based on the classification, you decide upon the surgical management. So these are the types. I'm not going into the details, which we all know. And the typical characteristics is genetics and risk factors have a role, because hereditary has a role in intermittent exotropia. We have seen to run in families, and risk factors mainly low birth weight. If there's any other neurological abnormality or craniofacial anomalies, and then the children tend to develop exotropia. The age of onset, almost 50% is usually at birth, and then the rest will be within the age of 5 years, and only about 10% in the age of adulthood. Sex distribution, there is a female preponderance. Precipitating factors, we all know: daydreaming, fatigue, sickness, and then again this Asia mainly because of ethnicity, and then increasing incidence of myopia. The other associated features along with exodeviation, you can have small hypertropias. As we see in this patient, there is a pattern deviation, there is an inferior-oblique overaction. There was some discussion going on whether we should deal with the inferior-obliques in these kind of patients. And amblyopia is usually very rare in these children, but then if there is an associated amblyogenic factor like an associated anisomyopia, then there is a chance that these children can go in for amblyopia. Usually asymptomatic when they are very young, and parents pick up and then bring them. Little older children can pick up transient diplopia, and then asthenopic symptoms can be present in these children. Parents typically bring them saying that the child closes one eye when it looks, when go out in the sunlight. That's called as diplophotophobia. What happens is when sunlight falls on the retina, it dazzles. The child tends to, close one eye. And then micropsia also is a symptom which is associated with the intermittent exotropia. So how do you assess these children? It's mainly by two methods. One is the subjective method and the objective method. Subjective method, you have two forms. One is a home control, where you ask the parents to chart out the number of hours of deviation, and the other one is the office control. Your New York clinic, you try to examine the child. A good control is one when the child remains orthophoric. Only when you try to patch, then the deviation starts. That is called a good control. A fair control is there is a deviation, and in the blink of the eye, the deviation disappears, or the child brings the eyes into orthophoric position, is fair. And the poor is, even if they try to do this, if it doesn't get better, then it is a poor control. The other objective methods to assess would be a distance stereo acuity and near stereo acuity. These are methods which will help you to also assess the progression of the disease, and then also helps you to plan for your intervention. And the Newcastle control score is a reliable score. It's very easy, and then it is also helpful to assess both in the home and the office, and the surgery is recommended if the Newcastle score is above 4. And this is just a video. The fact is very important in these children, because The patch test helps to control the tonic convergence. So this patch test can be put in the patient. Usually it was done for 24 hours, but half an hour is sufficient. It will mainly help you to differentiate between a pseudo divergence excess and a true divergence excess, and it should be done for distance measurement. Then why should we treat these patients? Because not all of them go into a constant tropia. Some of them remain in the phoric phase, and then some of them go into intermittent phase later in this stage. But then this is the natural history of the disease. And then how do you monitor the progression of intermittent XT? There is a gradual loss of functional control, sometimes which is evidenced by increasing frequency and manifest phase of squint, and there might be a development of secondary convergence insufficiency in some of these children, then increase in size of basic deviation and decrease in stereo acuity. This is one of the major, helpful tests to assess the progression of the disease. And how is this influenced is mainly by the tonic convergence of the patient, the age of the patient, and then the development of suppression, loss of accommodative power, and then divergence of orbits with increasing age. And more than anything, the progression usually occurs at distance than at near. So when you examine or measure these patients, always measure for distance. So what happens if you wait, if you don't treat them at the right time? There will be loss of stereopsis, the child can develop suppression, and there is a risk of underlying amblyopia. The management can be two modalities, non-surgical and surgical. Non-surgical usually in very young children who are not ready for surgery yet, or in small deviations, and surgical for other patients who have a larger angle or above the age group. Non-surgical options would be correct the underlying refractive error. You will see a difference. The underlying myopic astigmatism or a myopia, it is better to correct them, and with glasses some of these children are able to regain the control. And then overcorrecting minus therapy, I do not have a personal experience, but then you can give up to -1 to -3 again to increase the accommodative convergence which will bring the eyes to control. Part-time occlusion can be tried. Prisms, yeah, you can try brazen prisms, and orthoptics mainly to make them understand the deviation and to make them aware of the diplopia and to bring the eye to control. Botulinum toxin has a role, and the orthoptic treatment, as I already mentioned, is mainly to recognize or help the patient to recognize when one eye begins to diverge, and also to teach how to regain control of the exotropia, and again to increase the patient's fusional amplitude and improve the near point convergence. So we have this can be done with the help of convergence prisms, exercises and prisms, and then you have this the pencil push-up exercises, and then you have the prisms, the basin prisms, and mainly this is to control and to relieve asthenopia. So what are the indications for surgery? Increasing angle of deviation, deteriorating control, and then decrease in stereopsis for near and distance, and for cosmesis. So the operation depends upon, there are a lot of studies which have have given their reports, and they say if it's a child below the age of 4 years, there is a chance that child can develop consecutive esotropia, so it's better to avoid. Again, it's the surgeon's choice. And these are all the other signs of deterioration which we already talked about, so I'm not going to the details for want of time. So the surgical goal will be to immediately to get orthophoric stage or less than 10 prism diopters. It's always desirable, because sometimes more than 10 prism diopters, especially in smaller children, you can develop monofixation suppression scotoma. And if in older children we prefer, or adults, I prefer to do a little bit of ESO, little bit of overcorrection, because sometimes they drift again so slowly and then they come to orthophoria, but in children you have to be cautious. This timing of surgery, we already spoke about it. So surgery below 4 years of age, higher incidence of overcorrection and loss of stereopsis, and NAP suggested early surgical intervention to prevent development of sensory changes, slight undercorrection to prevent consecutive esotropia, and Jampolsky suggested accurate diagnosis and quantification to the amount of deviation. So preoperatively you have to evaluate all this. The only thing different than other squints would be to measure for distance, and then patch tests should be done to rule out pseudo divergence and assess the stereopsis for near and distance. And surgical procedures, you prefer to do a bilateral lateral rectal recession or a unilateral recess resect procedure. There is no generalized consensus, but then different studies have variable conclusions. So this is just a recommendation. For basic type, you would do a unilateral R&R procedure for the lateral rectal recession, medial rectal resection. For divergence, you prefer to do a bilateral lateral rectal recession, and convergence insufficiency and R&R with more amount of medial rectus resection is recommended. So this is a recommended surgery, and this is just a study which came out in the International Journal of Ophthalmology in 2018. They did a comparison of bilateral lateral rectal recessions with unilateral R&R, and they felt that the resect procedure shows an advantage over the bilateral at a short term. But then a bilateral lateral rectal recession is effective in long term, and then R&R is a choice for small angle deviations than a unilateral lateral rectal. Sometimes when there is the angle of deviation about 25 prisms, you tend to do about 8.5 LR recession, but then it says that a bilateral R&R would be better for these patients. So this is again the PEDIG's recommendation. They did not find any difference in surgical outcome between the bilateral recessions and the unilateral R&R. So the other factors which affect the outcome of surgery. So the criteria would be for success: orthotropia, restore alignment, better stereopsis, better binocular function, and to conclude, it's a very controversial question as there is no single method of treatment. So each case must be analyzed separately, and then depending upon the age of the child, the angle of deviation, and the surgeon's comfort, you should do a careful preoperative workup, meticulous surgery, and regular follow-up. Thank you.